there's a drug shortage that happens, that can take sometimes weeks, if not months, to resolve.
We've heard stats as high as 80 or 90% of prescriptions are now going out by delivery.
It's those on the lowest incomes that are being affected the most. And they're frankly making a decision about whether or not they're going to get their drugs or pay for other things.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. These are difficult times. Many older adults with chronic medical conditions likely depend on one or more medications to survive. What if those medications ran out? In the early days of COVID-19, many pharmacists feared that supply chain disruptions and drug hoarding could lead to shortages, and thus recommended limiting patients to a 30-day supply. The policy, however, resulted in people paying 3 times more in dispensing fees, not to mention needing to take more trips to the pharmacy. So what's the right course of action? Our panel will seek to answer this and more. But before we dive in, let's tee up the topic.
The COVID pandemic has hit seniors with high out-of-pocket expenses. The latest is in dispensing fees for prescriptions. In a move to avoid drug shortages, provinces and territories restricted patients to a 30-day supply of their meds rather than 90 days' worth. This means that people are having to pay 3 times more in dispensing fees. And for those taking multiple medications, the costs add up fast. CARP members take an average of 4 medications each, with some taking more than 10. And 15% admit to skipping prescriptions because of costs. Many fear this policy could mean more forego essential medications.
Now, before we get into the discussion, in response to an influx of calls and emails from members expressing concerns about this policy, CARP and our network of chapters have called on provincial and territorial governments to provide relief and support for seniors while this policy is temporarily in place. In Ontario, CARP partnered with the Ontario Pharmacists Association in an open letter to the Ontario government urging immediate and full coverage of co-payments in Ontario. Now, Alan, obviously, you're on behalf of the Ontario Pharmacists Association. You and I are clearly aligned on this subject. Why was it important for you to take this public position?
Well, it's a great question, Marissa. I think first and foremost, pharmacists are trying to do their very best during these very difficult times of COVID-19 to take care of their patients, to make sure that continuity of care is there. At the same time, we want to make sure that pharmacists at the front line are supported, given the fact that they are right on the front line. They are working without any additional support, such as personal protective equipment or any other types of support from the government. Right now, as a result of the policy, which we believe is important to make sure that the supply chain stays intact, that has led to a significant amount of increased work. It also has led to a significant amount of increased costs to pharmacies, recognizing that that many seniors are now being told to stay at home, and rightfully so. We need our seniors and many others in our society to stay protected. But this means, the policy means that we're going to be looking at increased frequency of dispensing, and we're going to need to take care of our seniors. Pharmacies have therefore had to deliver medications. So the costs seem to have escalated significantly, and it's why we're looking to the Ontario government.
You know, Dean, as a pharmacist, you too, you're on the front lines. A lot of people have written in and said, well, why can't pharmacists cover the cost? I wondered if you would share just sort of what it entails to even fill a prescription. What are some of the other, additional steps you've had to take during this time?
Thanks, Marissa. Yeah, when people look at pharmacy pricing, there's a real lack of understanding because there's really 3 components. There's the cost, there's the upcharge that's added as kind of to control the inventory, and then there's, of course, the dispensing fee. All of that sort of goes in, and depending on drug plans, and it's really a very, very complicated subject on pricing, and probably too complicated to talk here. But over the last 6 weeks or so, we've seen in pharmacy significant changes. And I think anybody that walked into a pharmacy today would kind of go, wow, that doesn't really look like pharmacy I'm used to. I mean, there's plexiglass barriers and plastic sheeting, and pharmacy staff wearing protective gowns and gloves and masks and face shields like any other healthcare professional. So all of that stuff has been at the cost of the pharmacists. And as Alan pointed out, it's significant. And so we've had, besides all that stuff, nobody wants to come into the pharmacy anymore, so everything's being delivered, and you can imagine how much that costs.
Dr. Gorfinkel, what do we know about drug shortages? Are you able to answer that? Because a lot of people have said, well, I don't know that my drug necessarily is experiencing a shortage, and why was this policy so writ large?
One of the huge issues we're facing is the lack of transparency around what drugs are actually in shortage. And I wonder, does anybody even know? I spoke to the pharmacist in my building about this very topic. And although she puts in an order for a certain amount of medication, she only learns what she's going to be actually delivered when she gets the delivery. So that's a bit of a problem, right? If the pharmacist herself does not know what is being in shortage, then how are we to know as clinicians? And what are patients to do about it? I really question, should this be across the board? Because I'm concerned that seniors, in fact, are going into pharmacies more frequently. Seniors are facing higher costs with, having to pay dispensing fees that range from $5 to $15 per drug per month. I mean, it really does add up.
Alan, can you answer that question? I mean, I've heard things like Ventolin and insulin are experiencing shortages, but what about thyroid medications and other things? Do we really need to be restricting every patient who's on every type of medication for a chronic condition now or what have you to a 30-day supply?
You're right, Marissa. Things like salbutamol, Ventolin inhalers, that's a very critical shortage that we're facing right now. Seriously, because we see patients in hospitals, in long-term care homes, even in the community, who are dealing and trying to recover from COVID-19. They are needing that medication because it's a respiratory product. Yet you've got millions of individuals, seniors, adults, children, all also requiring it for basic treatment of asthma and other respiratory conditions. You're right. There were some challenges with insulin. We've been told that some of those issues have been resolved. Other medications have also been short, and we've had this discussion before, issues around drug shortages that pre-existed COVID-19. There were some issues with manufacturing that was happening offshore, raw materials that were tainted with a carcinogenic ingredient. So a lot of these products that are short right now have been short for a long time. I would even go so far as to say we've been dealing with drug shortages for probably the better part of 3 years, probably longer, but most significantly over the last 3 years. Pharmacists have been managing those very quietly. That's the way they function. They don't make a big noise out of that. What happened with COVID-19 is that it exacerbated that. The policy was put in place by the Ontario government, and in fact by most governments in the country, supported by pharmacy, because this was meant to be a proactive, a preventative approach. The problem is that we can't wait. We don't really have the luxury of waiting for drug shortages to occur and then trying to manage them. With drug supply, when there's a drug shortage that happens, that can take sometimes weeks, if not months, to resolve, simply because a lot of the products come from outside of the country. And so we needed a proactive, preventative measure. We don't have a crystal ball. What may be available now may not be available in 3 months' time. And that's why we needed to look at a 30-day supply to make sure that all medications are protected so that patients have them when they need them.
All right, we need to take a short break. When we come back, we'll hear from CARP members who've been directly impacted by this. Stay tuned.
52% of seniors are on inappropriate drugs. That is a huge number that carries with it tremendous implications.
Welcome back. When it comes to prescription drugs, CARP members are super users. In the context of a 30-day prescription limit, these costs add up fast. Such was the case for one of our members who called in to share his story. Have a listen.
We found out about it when we had to renew our Walmart prescriptions. And I was surprised when the bill was so high. And I found out that Walmart was charging $4.11 for each 30 days. And when I did the math, because we're high users of prescription, I found out it would cost me $640 more a year in prescription cost. And then I began to research this and found out that all the 5 Rexall stores in Barrie only charge 1/3 the cost for a prescription refill for 30 days. So I talked to the Walmart lady, and she says, "I'm so sorry to tell you, but this is a corporate decision, and it's not a store decision." And so I was like really upset at that and quite let down. Last Sunday, I had to decide whether I would switch to Rexall or stay with Walmart. So I phoned Walmart and spoke with the store pharmacy manager, and she said, because you have been a long-time customer, she said, we will give you your prescriptions for 30 days for $1.40 each. I asked her, I said, is this a change to the Walmart corporate decision? She goes, no, this is a store change. It's only from me. At that point, I was very happy for myself. But I know that everyone else is still having to pay $4.11 for 30 days. And I still don't think that that's appropriate for Walmart to do that. They could have done their thing and helped out in the COVID situation, just like Rexall did.
You know, Dieter's story really speaks to the latitude that pharmacies have when it comes to charging certain fees or the co-payments. They are able to cover some of those costs, and they do in certain circumstances. And clearly, what's happened here with Dieter is one example of that. Now, Bill, we've surveyed CARP members on this, and on average, our CARP members take 4 medications each, some taking more than 10. You know, these costs add up. And I know that I've personally heard stories, and I'm sure you have too, about people foregoing essential medications because of costs. You know, how serious an issue is that today?
It's a very serious issue, and I realize it's an unintended consequence, that there were good reasons that people felt that we had to have some kind of controls, but it's hurt those who most need the drugs. The drugs that we're hearing about from our members are adding up to hundreds and hundreds of dollars that they're paying more in the prescription fees. And it's those on the lowest incomes that are being affected the most. And all we've asked is that government, for the time being, as they're covering other extra costs people are having during the COVID-19 pandemic, that they cover these costs for our seniors who are most at risk and need their drugs on a regular basis.
Dean, you know, again, you're on the front lines. Have you had people come in and express concerns about the added costs and inability to pay? Do you have any concerns about people foregoing medications because of these costs? And what steps are you taking to help mitigate it in the absence of any government action?
Well, I represent a group of independent pharmacies, and certainly, you know, we've heard it. It started, you know, back in mid-March when, you know, some of the changes around the 30-day policy were put into place, and since then, it's been, you know, a lot of discussion amongst the pharmacists to the patient about not only their medications but costs as well. So, you know, I think that's the nature of what the Ontario Pharmacists Association, our association as pharmacists, has been working with CARP to not only make it a little bit easier for seniors, but also to make it a little bit easier for pharmacists as well.
Dr. Gorfinkel, are there any lessons, opportunities in this?
First, that cost-related non-adherence, in other words, not being able to take prescriptions, is in fact directly related to costs. So there is a metric that the more somebody has to pay out of pocket, not surprisingly, the higher the non-adherence, the higher the likelihood it is that they're not even going to pick up their drugs. They simply can't afford them. And in fact, if we take a look across Canada, there's over 1,000 deaths, and that's just between diabetes and cardiovascular deaths. I'm not including anything else. I'm not looking at cancer drugs. Just between diabetes and cardiovascular deaths, over 1,000 deaths in a year that can be attributed directly to cost-related non-adherence. That's a huge number. And I want to throw in another interesting statistic, that over half of seniors, it's 52% of seniors, are on inappropriate drugs. That is a huge number that carries with it tremendous implications. So I would look at this kind of as a carrot and a stick. And what is the carrot? This is the potential for seniors to go to their doctors and say, I want a full drug review. Let's look at my drugs. What can be de-prescribed? What can I get rid of? That's actually a really important question. And that's the carrot, because probably in getting rid of that, you may reduce fracture risk, you may reduce the likelihood of falls and forgetfulness. So let's look at that. That's the carrot. And then, of course, the stick is, let's move away from those high, expensive dispensing fees every single month.
Alan, I just want to squeeze you in here before break. You know, Alberta took steps pretty early on to mitigate some of these costs for people on their public drug plans. We do know that Atlantic provinces have taken some steps in the right direction. New Brunswick actually reversed its policy. In some of the discussions you've had with Ontario, what's your sense about where they're going with this?
I wish I had a clear-cut answer. I don't know. I think the message, from what I'm hearing, message is being heard by government. We know that, you know, dealing with, in the largest province, dealing with all of the costs associated with taking care of patients on the full gamut. When you're looking at the issues in long-term care, looking at hospitals, their costs are significant. But that does not mean that they should be turning a blind eye to this. We are urging the government to take a look at this. This is a supply chain issue. This is not really, first of all, it is a temporary issue. This is not meant to be a long-standing policy. It never was. But this is to protect the supply chain. Government needs to step up. This should not be falling to patients, most certainly. And this certainly should not be, passed down to the pharmacy provider, who's doing their very best to take care of their patients, to deal with one-off situations whenever they need to make, if they need to make a clinical exception and issue a 90-day supply based on certain types of medical circumstances, they're prepared to do that. But we need government to step up and to help seniors and to help pharmacy.
All right, there's more of the Zoomer when we come back. Don't go away.
There is an opportunity for us to relook at our health system and look at what it is that, you know, what did we learn?
Welcome back. CARP's received several dozen emails and calls from CARP members and others on the subject of restricting prescriptions to a 30-day supply, including from Sharon in Newfoundland and Labrador.
This has affected my family, my husband and I, because it has increased our prescription requirements to go to the pharmacy at least 3 times now instead of once every 3-month period. But the cost is what is the biggest thing. My husband is a diabetic and a leukemia patient. And I have some medications as well that I take. On an average, we would spend probably about $100. That has multiplied 3 times now to about $300. But I've heard from other people who have called me, they've got worse stories than mine. A friend of mine, it's $200 a month that he had to pay the other day, which has now exponentially increased to $600. And another lady for whom my heart broke was about $800, and that's gone up now to $2,400. But when you add $300 to someone's budget or $2,400 to someone's budget, that is just unacceptable. My question would be, can we have a strategy that would direct its attention to the origin from which this change in the prescription refill program from 90 days back to 30 days?
Thanks, Sharon. Your point is so well taken. The real concern, obviously, is that such a policy could force people, seniors even, to make trade-offs of necessities, from choosing to eat or pay rent or pay for their prescribed medicines. That in turn results in much higher costs to provincial healthcare systems. And at the end of the day, this decision to implement this policy, it did come from government, and perhaps, all the implications weren't fully thought through. What we at CARP obviously need to continue to do, as we have been, is to sort of demonstrate that there are real costs associated with this, and to fight to ensure that the cost of protecting our supply chain doesn't fall to seniors. But Bill, is there anything you'd like to add?
Well, Sharon is right. Here at Atlantic Canada, what we're finding is, first of all, for those people who are covered by a pharmacare, a seniors pharmacare, or a family pharmacare program, they have some relief in the provinces that have decided to pay the extra fee. However, they still have those extra costs of getting to the pharmacy on a monthly basis rather than going every 3 months. And they still have to pay their deductible, which means these upfront costs still are applied to them in the first 3 months of their program. So they have to pay out-of-pocket money earlier that they wouldn't have had to pay otherwise. The other group that are falling between the cracks are those people, especially, as she mentioned, people on private and even some government pharmacy plans, which don't cover them for this at all. So they're still left paying the whole amount.
Dean, I'm curious, because pharmacists do have latitude in issuing 90-day supplies despite these mandates. And so how often is that exercised?
Pharmacists, have that flexibility. I think if you look at any province across the country, these policies were put in place, but they were usually communicated as recommendations, or if giving the pharmacist the latitude to be able to work with that patient under certain circumstances, as described, where we can soften the blow a little bit. So I don't think it's not a cut and dry, has to be 30 days type of thing. But to answer your question, it happens a lot.
More than not. Well, Alan, and then I would also ask, how often do pharmacists cover the cost for people that come in and say that they're struggling to pay for it? When do you use your discretion, and how often is that exercised?
We are a voluntary association, so we don't collect that type of data. Nor does do I believe does the ministry actually see that. They may see instances here and there, but I don't think they are able to actually collate this. It speaks to a bigger issue, and I think there's some tremendous opportunities now, once we get through this horrible pandemic, for us to take a really hard look, and I think Dr. Gorfinkel addressed this. There is an opportunity for us to relook at our health system and look at what it is that, what did we learn, and how do we fix this? But we do know that pharmacists are being, they're very sensitive, they're very attuned to the issues. We're asking for many individuals, if possible, if they can cooperate and hopefully understand the issues. And what I'm hearing is there are many pharmacists that have been telling me that once they've explained to their patient what the issues are, then they're a bit more sympathetic. They're recognizing this is not a pharmacy implemented policy. This is a government policy, And as Dean said, it's not a mandate. It's not an absolute. Pharmacists will exercise the discretion. And I'll use an example in rural and more remote areas where an individual can't get to a pharmacy, or deliveries are very difficult because of the territory. Pharmacists are dispensing 90-day supplies in those cases.
All right, well, we need to take a short break. There's more of the Zoomer when we return.
No provincial or territorial government is covering the Prevnar 13. That vaccination reduces community-acquired pneumonia by 45%.
Welcome back. Before we get into the next issue, we have one last question from Drew in Richmond, BC.
In March, the Nova Scotia provincial government stated that effective immediately and for the duration of the state of emergency, patients will only be responsible for the initial co-payment on a 90-day prescription. My question is, can we not expect all other governments or the federal government to do the same for both government drug plan holders and individual plan holders who are required to purchase drug plans privately? In the case of private plan holders, they will experience the hardship immediately and also in future through premium increases. Thank you.
All right, Bill, I'll get you to respond to Drew, and then also maybe consider, what are some things that seniors can be doing now? Because, many don't know that pharmacies do have latitude, that pharmacies do deliver medications, for example.
Right. Well, first of all, Drew is absolutely right. In Nova Scotia, they have the government is paying the extra dispensing fee for people on the pharmacare plans, the senior pharmacare plan, and the family pharmacare plan. But that's only hitting a percentage of CARP members in Nova Scotia, and the same is true in New Brunswick, where they removed it entirely, but the costs are still there, and Newfoundland still has to move on it. So yes, we need to make sure that everybody is covered by any decision the government makes, not just those on the plans. The biggest problem that seniors are dealing with right now, right across the country, is how do they handle the extra costs and the extra pressures involved in the kind of restrictions that are on them. And the one around 30-day prescriptions is an extra one that surely they don't need.
As older adults evaluate how much additional they're spending on prescription medications because of policies like this, they still also, Dr. Gorfinkel, have concerns around medications that can protect and maintain sort of a healthy baseline that continue to not be covered by various provinces. Last year, 6 provinces covered the high-dose flu vaccine, for example, in long-term care homes. 1, just Ontario, covered it for all seniors over the age of 65. With what we know about this virus, how important is it that governments look to funding critical vaccines that'll help boost people's immune systems, even if they're not specifically related to COVID-19?
It's tremendously important. And when we're talking about respiratory vaccines, you mentioned the high-dose flu vaccine, which was in fact covered by Ontario. That said, what matters most is that people simply get the flu vaccine. What is very concerning is that the government is still not covering, as far as I know, no provincial or territorial government is covering the Prevnar 13. That vaccination reduces community-acquired pneumonia by 45%. It also impacts on hospital-acquired invasive type of pneumonias. And in the face of a pandemic like we're now facing, which is a respiratory disease, we know that pneumococcal infections are massive in hospitals. So yes, they should in fact be covered. It is an expensive vaccination, but one worth having.
Alan, one of the things that Dr. Gorfinkel mentioned is just around accessibility. Yes, cost is a big barrier, but pharmacies, to what extent do pharmacies across the country, not just in Ontario, have the ability to administer these types of vaccines? I know in Ontario, high dose isn't for example, offered through pharmacies?
Pharmacists since 2012 have been given the authority to provide injections, and it started with the flu vaccine, and we've seen the tremendous value in terms of immunization rates just on regular influenza vaccine as a result of inclusion of pharmacists. What was very disheartening is that seemed to be the only vaccine that was real of a publicly funded nature that pharmacists were permitted to administer. There are travel vaccines that pharmacists can administer, but these are not publicly funded vaccinations. When it came to the high-dose flu vaccine, we were particularly disappointed that pharmacists were not identified as a center where patients could go to get that much-needed vaccine, that much-needed protection. And what we were forced to do was we were forced to redirect patients, particularly seniors for whom the vaccine was intended. We were forced to redirect them to their primary care physician. It's not something we ever want to have to do. Whenever we're trying to move immunization rates upwards, and here we are, we're redirecting some of our most vulnerable to another healthcare provider that's, I would arguably say, is a more difficult, it's a more difficult appointment to schedule. Pharmacies, you walk in, you can get that vaccination, but we never want to turn away someone who's made the decision to get that protection. We're continually advocating for increased authority in terms of providing, whether it's high-dose influenza, pneumococcal vaccines. We're asking for this ability because it provides a much greater degree of convenience for those who are most needing it, those most vulnerable.
All right, when we come back, medical experts warn of a second wave. When and how severe, we'll discuss.
We're very afraid that governments are so fixed on the COVID-19 problem now, they're not planning ahead, and we're going to pay for that lack of planning in the fall.
Welcome back. Health officials across the globe have warned that there could be a second wave of the COVID-19 pandemic. Could this happen in Canada? Would it be worse? And how are we preparing? Dr. Gorfinkel, I'll go to you first for your thoughts on this.
Well, I don't think it's even a question that we can expect a second wave. We cannot clearly maintain the kind of social distancing, hand washing. Possibly, yeah, we could do that. But in terms of closing all of our schools, closing workplaces down, that's not sustainable in the long run. So as we do this gradual dance backwards and lighten up a little bit on some of the restrictions, we'll have to wait and see exactly what the public health ramifications are going to be. How many more cases are we going to get? It's not a question of, will we get more cases? Obviously we will. The question is, will it stay under the amount that we can actually manage? One of the huge things that concerns me is the fact that patients are not going to hospital now. That's extremely concerning. And in fact, hospital emergency room visits for things like heart attacks and strokes are down 40%. That's a major concern. These things are still happening, but what's happening is people are so terrified of going to the hospital, they're so worried about getting COVID-19 or being a burden on the system that they're simply not going. And what we're afraid of is that that's going to cause an increased burden of disease, and it's going to cause an increased number of deaths.
You know, how are people preparing for this second wave? Dean, I'll go to you. What are pharmacists doing to prepare?
We've heard stats as high as 80 or 90% of prescriptions are now going out by delivery. And that's kind of the root problem around this financial piece. But you know, people are not only scared to go to a hospital, but they're scared to even go in a pharmacy. So it's you know, that's a huge learning that, you know, I think for pharmacy, you know, we've got to prepare to go virtual. We weren't prepared before. So, you know, a virtual medication review is now allowed in Ontario. Virtual physician visits have been enabled. So, you know, this is all the new reality. And I think that's one of the huge learnings as we go to perhaps a phase 2 or phase 3.
But, you know, Bill, we spoke about earlier, many people just don't know what they can take advantage of, I think, in this environment. And I think it's just really, it's a matter of getting the message out and letting people know, isn't it?
We don't communicate well with our senior population. The young people in communications department and governments and others think that everybody does social media. And we know that in terms of getting information, something under 50% of people over 65 get any of their information from social media. We have to find a way to communicate better with seniors so they understand what's available to them. And we have to learn better to plan ahead. We're very concerned in those provinces that don't have the high dose flu vaccine available other than in long-term care facilities, that has to happen for next fall. We know that the high dose is better for the age group that we're talking about. It will prevent problems in the future, but unless it's ordered soon, because you don't just phone up and get it right away, unless in the next couple of weeks governments go ahead and order it for the fall, we won't have it available for next year. We're very afraid that governments are so fixed on the COVID-19 problem now, they're not planning ahead, and we're going to pay for that lack of planning in the fall.
Alan, we started this show talking about the added costs associated with this 30-day supply. Yes, New Brunswick has reversed it. Other provinces have stepped up. We keep saying that it's going to be temporary, but then we warn about a second wave. And I'm wondering, you know, are there steps being taken now to mitigate drug supply shortages? Is there something that pharmacies and others can do to prepare for this second wave?
There's very little that from a pharmacy perspective that we might do differently in our current situation, because quite frankly, you know, the supply chain is the supply chain. Pharmacy does not have control over distribution of raw materials that come from China and India. A lot of our products are reliant on non-Canadian sources. We can't predict delivery schedules, transportation from those countries to Canada. We can't control the deliveries from wholesalers to pharmacies. All we can do is manage, and I think we started with, you know, not knowing what you're going to get in your order until the day it arrives. Pharmacists are going to have to learn to adapt. I'm not sure if I think the lessons learned from a 30-day supply there's a lot of things that we can take away from this and find ways to mitigate. But we need to work with government. Government needs to come to the table with the health providers. In this particular case, when we're talking about medication management, and managing the drug supply, they need to come and talk with the Pharmacy Association so we can plan proactively on this. Without that dialogue, we may be in a similar situation.
All right, we need to take a short break. When we come back, final thoughts from our panelists. Welcome back. It's that time in the show for final thoughts from our panelists, and we'll start with Dr. Gorfinkel.
I get that we cannot control the drug supply. We have no control over how much drug is going to come into Canada from India and China. We're kind of at their whim. But what we do have control of is smarter use of that medication. And I would implore patients to take a more proactive stance in their own health care. What does that mean? Start checking your pulse, start checking your blood pressure, start checking your temperature and your weight, have your drugs at the ready for your doctor to review, and let's make sure that whatever you are taking is smart prescribing. It's sensible prescribing, that every single drug on that list is actually doing something positive in your life.
Bill.
We have to learn from the evidence of what's happened now and fix those healthcare problems, especially in the area of drug supply, before this happens again. Governments have to look ahead and plan ahead. And for the patients right now, we all know there's no question that the number one place that patients go to get almost all their information is from their local druggist. So do that, talk to them. Don't be shy. Don't be afraid to admit that finances or other are a problem for you. Don't be too proud. Ask the questions. That's why your local pharmacist is there, and he will help.
Alan.
This is something that needs government support. Pharmacies are feeling this issue as that the messenger is being shot here. We're just trying to do our level best at the front line. But I echo what Bill has said. We would encourage all patients, seniors and others, to talk with their pharmacists to find ways to navigate through these very difficult times. These are temporary times. I think it's also imperative that from the perspective of the profession, we need to do a better job explaining what it is we are doing right on the front line, what's going on behind the scenes, so that the work that pharmacists are doing is truly understood and valued by everyone in the health sector.
And Dean.
The good news, I can finish off with some good news here, is that March, because of the craziness of March, and nobody could get a salbutamol or Ventolin inhaler if their life depended on it, has kind of forced us to, up our game a little bit. Work with the manufacturers, work with the distributors to remove the filters and allocations and barriers that have prevented patients from getting it. Like I said, 6 weeks later, we're in a way better spot as far as drug supply. We're already starting to hear the rumblings of the 30 days being lifted, to back to the 90 days. So I think it's, it was a great learning for us in pharmacy. I don't think it's going to last that much longer. I can't predict, but I think we're gone by the worst part of it, and now it's brighter days ahead.
That's certainly hopeful. All right, well, that's all the time we have. Thank you to my panelists for being here and for your expertise, and to you at home watching. We'll see you soon.